Well, welcome everybody. We're going to be talking about the genetics of heart disease. And this is something that's near and dear to my heart because I'm going to share with you some personal information about my genetics, my journey on cholesterol. We have really a stellar crew presenting tonight. We had some sort of a dry run last night, and we changed everything, like always, and we keep getting better. And I'm really excited about tonight's program. And how's your week there, Stuart?
My week's been not too bad. I've been doing a little bit of studying. I have a test coming up next week, so kind of nervous about that. And other than that, I've just been trying to get a little bit of sun while it's still there, and just hanging out with my family a little bit.
Nice. We're hearing some background echoes there. Can you Can you fix that problem?
Yeah, I'll take care of that.
All right. And why don't we just get to the next slide there? Is that okay?
Yeah.
Well, this is kind of an interesting slide, and on the far right, you see yours truly with the two newest additions to our family. Little, I think you saw those pictures before. Those little chicks are growing up, and the thing about the chickens, they're not going to eat them, right? So they're pets, and some people might eat their pets. I don't eat my pets, and I'm going to try to train them a little bit. I'm not going to train chickens yet, but I'm going to figure that out. In the middle, you can see that heart disease has lots of causes, and one of the things we're going to explore today is how does cholesterol and triglycerides play a role in this. On your left, we're going to talk about next week about on weight management. And one of the problems with weight management, as you gain weight, you have this inflammation that takes place, and you have lots of medical problems from diabetes, high blood pressure, renal insufficiency, depression, kidney failure, stroke, heart disease, congestive heart failure, and that all leads to feeling miserable. And what I'm seeing right now is this pandemic of basically heart failure, and we're going to talk about more over time. So to me, the best way to decrease my inflammation is to lose weight and exercise, and that's the best way for yourselves to look at that. So we're going to spend quite a bit of time on the best strategies for weight reduction next week, from both surgical and from medical therapy. Well, that's next week's discussion, because I'm sad to see too many people think to me, I just have no more energy. What's happening? Well, people are wearing out their bodies, and we have to figure a way to make our bodies stronger. We'll share that. Next slide, please. Now, when we talk about genetics, so one of the things is genetic loads the gun, lifestyle pulls the trigger. And we're going to try to explain that a little bit more detail. Here's yours truly out on my bike. And as you can see, that's my Ancaster to Paris shirt. I was kind of proud of that shirt I got a few years ago. I did 70 kilometers, and the year before, on the 70-kilometer race, someone tapped me on the shoulder. It was the marshal. Say, "Sir, you're in last place. You're going to have to stop." And so I trained harder for the years afterwards. I'm still towards the back of the pack, but I'm not in last place anymore. And I'm getting fitter, and I really enjoy this. On your right is myself and my daughter, Jenna. We're going to talk about genetics. And what I want you to think about is, what do you think my cholesterol is and my daughter's cholesterol? Because we're genetically related. Well, we're not really, because Jenna's adopted. And for people who undergo genetic testing, sometimes there's some surprises to find out who the dad and the mom really are. So if you do go for genetic testing, you might be surprised a few things. So it's always something to keep aware of. And that was Jenna's cake when she basically graduated from high school. So she's off to a new beginning. So very excited about that. On your left, we see two of our masks of the week, and we can see that we're a mixture of young and older people. I always say young people are skinnier than us older people, but we're getting skinnier. And hey, by the way, Stuart, how much do you think I weigh this week?
How much was it? How much was it last week?
172 last week.
I'll say 170.
Yeah, 171. So,
Okay.
so I'm inching my way downward. I'm getting close to that magical 165, and so it's been a long, hard journey. But if I can do it, you can do it too. And yeah, just keep trying in different ways. You can say I can't lose weight because of genetics. My answer is genetics loads the gun and lifestyle pulls the trigger. So how do I make that a better interaction? Next slide, please. And again, is that if you look at this young guy here, he's quite fit. He's doing extremely well, and you can see that he does a lot of walking and a lot of exercise. So my advice to everybody is still the best way to prevent Alzheimer's disease is to walk, 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 and if you can't walk, crawl. Keep moving, because what happens over time, you get this inflammation. Inflammation is bad for the heart, other organ systems, bad for cancer, and there's new guidelines on the management of weight reduction, but to me is that I'm changing my eating habits, I'm working hard at this, and I'm changing my lifestyle. And remember, tonight we're going to do the stairs afterwards. That should go upstairs. Come join us if you'd like. Tomorrow morning, Dino and I are starting tennis at 6 o'clock at Linden Park. We got there around 5:30 this morning. It was kind of dark at that time still. The days are getting shorter, and so we're now playing tennis at nighttime, and the bike ride is at 11 o'clock for anybody that's interested at Linden Park, just past Dundas towards Brantford. So come join us, and the more the merrier. Next slide, please. And you can see that you can look at that smile there. I love that. Can you smile behind a mask? Here's how you can smile with a mask on. You can matching, and you can see me again with the bike. And on my left is my friend Jordan. He's one of my heroes. He's lost 60 pounds and doing well. And does anybody want to guess what my cholesterol is? I want you to sort of think about that. And Rachel, what do you think my cholesterol is? Anyone. So if you were going to just look at myself or my son, what do you think our cholesterols are? Just looking. You know what my cholesterol is, so it's not a really fair question. But do I look like a guy who has high cholesterol?
Not to me.
Okay.
Just off the surface, you have a bike with a helmet. Jordan looks very slim and tall. Like it doesn't really fit the typical profile of someone who would have high cholesterol in my mind.
Okay, so we're going to come back to that later. So I'll surprise you, and if you look in the middle, we can see a surprise. The Montreal Canadiens just defeated Pittsburgh. Pittsburgh's out of the playoffs. Montreal's in. So Montreal wasn't predicted to do well, and you can see what hard work and a little bit of luck and perseverance. I think the Montreal Canadiens have a very high polygenic score for winning hockey games, and we'll explore that a little bit later. Right now you can get different pizzas. Chad, I see you on there. This is actually my wife's pizza. It's better than yours, so there you go. And so you can see that you don't have to have meat on pizza and almost no cheese whatsoever. And you can see on the top is a person of a dead person with a heart attack. And so remember, heart disease is still a major cause of killing us in North America, and we're going to try to find better ways. So if you do things right, you can live to over 100. If you have bad genes for cholesterol, and if you don't treat it, you can be dead before you're 50. And so, and how you look doesn't necessarily determine what your cholesterol is. So Rachel's absolutely right. I don't fit the typical profile of high cholesterol, neither does my son, but guess what? We have a cholesterol problem in the family. And so one of the things is knowing your genes and knowing what's going on and knowing your risk factors. If you don't have gene testing, which is not readily available, know your family history. And your family history is a very good way of knowing what you're likely to have in the future. And we'll explore that a little bit later. So remember, if Montreal can beat Pittsburgh and I can lower my cholesterol, and what I'll say is that you should know your values, and you should keep track of it. Remember, Paul did an excellent video on how to get results through the labs, through Life Labs and Dynacare. You should be in control, or at least know what your values are, and I think that's really important. So next slide. So I'm going to be quiet for a little bit, and I'm going to let our team take over. Remember is that there's so much you can do to empower yourself, and let's learn a little bit about the genetics of cholesterol.
Okay, thank you, Dr. Kearney. So then today we'll be talking about genetics in heart disease, and specifically how cholesterol can lead to heart disease. So there are 4 main sections. First, we'll talk about genetics, what that is. For people who haven't been to high school for quite a while, we'll go into a little bit of high school biology and tell you what genetics mean. Then we'll talk about the impact of your genes on cardiovascular disease. So how much of an impact does your genes actually have, and if there's anything you can do about it. We'll delve into the specific genetic lipid disorders that we have prepared. There's 3 in total. And one specifically called Familial Hypercholesterolemia. You've probably heard Dr. Kearney say a number of times before. Is one of the most common mutation or common genetic disorders in the world, and we'll spend a bit more time on that. And last but not least, once you know your genes, you might not be too happy with what your genes tell you, but what can you do when you have a quote-unquote bad genes or not the most ideal genes? And we'll talk about that too. All right, so intro into genetics. What is genetics? Every human has characteristics that can be passed on to the next generation if we were to have biological children. This is called heredity. And heredity applies to both visible and invisible characteristics. So the color of your hair would be something that's visible, you can see on the outside, but your predisposition for cardiovascular disease or for diabetes or cancer or your cholesterol levels, those are invisible characteristics that you can't just see when you look at someone. So all of these characteristics, it doesn't matter if you can see them or not, can be passed on to the next generation. And these characteristics are decided by segments of DNA called genes. So genetics is the field that studies genes, the variation in those genes, and the process of passing them on to the next generation. Clinical genetics specifically looks at how these genes are related to disease and how we can help counsel or treat families who are affected by genetic disorders or hereditary predispositions. So this is clinical genetics. We're talking about heredity and genes. There's a new word that's coming around the block. It's called polygenic risk score. And we're going to be talking a lot about the concept of a polygenic risk score. So each of us carry hundreds of genes that increase our risk for various diseases. But that doesn't mean that we will all get those diseases. They're risks. There are over 300 genes that have been associated with an increased risk of heart disease. And we probably all carry some variant of these 300 genes. There are some variants that will increase your risk of heart disease. There are some variants that decrease risk, and some have no effect at all. Most of these individual gene variants have only a tiny effect on the overall risk of disease. But all these tiny effects, like snowflakes in an avalanche, like raindrops in the ocean, they can add to each other and have an additive effect. And when they're all added together, you can get enough risky variants to start increasing your risk of disease. So the polygenic risk score is basically adding all the genetic variants that we have and calculating it into a score that we can use for risk prediction. So you might be a little bit confused about what gene variants are, what do you mean by additive effect or tiny effect. We'll be going over all of that in just a moment. But for now, just know that the polygenic risk score is basically a score that tells you, based on all the tiny little gene differences you have in your body, what your risk is compared to the population average. So here, we actually have a copy of Dr. Kearney's genetic testing result. He was tested for something called familial combined hyperlipidemia, and we'll talk about this specific disease a bit later on. So this is what you might see when you get a genetic report. You have the person that's being tested, that's also called the proband, which is the person being tested. You have what they did in the test. They tested for all of these genes that, for most of them, I have no idea what they do, but they bolded a useful section here telling you the summary or the conclusions of the test. First, they have not detected any mutations. Mutations means radical changes in any genes, and we'll go over what that means or what that looks like. So Dr. Kearney doesn't have any mutations that will cause familial combined hyperlipidemia. They found common polymorphisms. Polymorphisms are basically variants of something that is normal. So common polymorphisms have been found. Having a polymorphism does not mean that you're at increased risk or decreased risk. It just means that you're different. So this is basically what they found, no mutations, but they found some variants. They also calculated Dr. Kearney's polygenic risk score for both his LDL cholesterol and his triglyceride, Pg. And in terms of the polygenic score, you don't want to be in the highest percentile. The higher you go, the more risk you have. So when looking at the polygenic risk score, you want to be at a low percentile. That means you're at low risk. For Dr. Kearney, he would be an A student if this were his grades, but this is his polygenic score. That means he's basically at high risk for having high LDL and high risk for having high triglycerides.
So if I got that right, is I don't have any specific gene mutations that are considered deadly for cholesterol, but I have hundreds of genes that have different shades that put me in the top percentile, 92th percentile and 95th percentile for cholesterol and triglycerides. So by this testing, I'm up Schitt's Creek, so to speak. I'm at very high risk for high cholesterol and triglycerides. And it's not based on a single gene problem. It's basically the orchestra of my entire human genome that's contributing to give me a tendency to both high cholesterol and high triglycerides. So Rachel was right when she said I don't fit the profile as someone who has a high cholesterol, high triglyceride, but my genes point me to that direction. And the same thing is that my son also is inherited some of those genes as well. And so that means if I do nothing, I'm very likely to have heart disease in the age of 50 or even shorter. I'm now 60 and I'm still kicking, and I'm kicking harder than ever. And I've taken the steps to protect myself, and these are the steps that you need to think about too as well. And we'll talk about that a little bit more later. Next slide.
Okay, so we've thrown a lot of vocabulary at you in the past few minutes. We've talked about gene variants, we've talked about polymorphisms, we've talked about gene mutations. What is really the difference between those? So because I like cheesecakes, so we're going to be using cheesecake as an example. Imagine all your genes combined to make a recipe. So your genes would be the individual ingredients on this recipe. This is an original recipe, so that's the standard genes, we'll say.
By the way,
cheesecake.
Rachel makes an excellent cheesecake. She's an excellent cook. I miss her cooking, and she's also a very healthy cook and a very good cook. So this is very important information we're learning here.
Okay. So original recipe, a genetic variant or a polymorphism would be something like substituting sugar with brown sugar. So it's different, but it's a reasonable replacement, and you'll see this replacement all the time in baking. Or you might substitute lemon juice with lime juice because you might not have lemons available. Maybe you want 1 tablespoon less of butter, or you substitute the cracker crumbs with wafer crumbs. My mom does that. It tastes amazing. So this is a genetic variant. And as you can see from these two recipes, you wouldn't say this variant is at a higher risk or this cheesecake would taste less Yummy. So this means that it's just a different recipe. There's no increased risk. And this is what we mean by you have a column polymorphism or you have a genetic variant. That does not necessarily mean that you are at an increased risk just by having these variants. However, there comes a point when you get too freestyle with the recipe and you start replacing too many things. If you replace butter with canola oil, yes, that can work. In baking, that does happen. You can replace butter with the canola oil if you want to be healthier. You can replace sugar with maple syrup in some recipes too, as well as sugar with honey, flour with whole wheat flour. If you look at all these variants individually, they make sense. They're all legit and reasonable baking substitutes, and people use them all the time. But when you look at this whole recipe as a whole, you will, at least I am looking at this recipe and I'm thinking, okay, this is probably not going to be a very good cheesecake because of all these substitutions that you made freehand, and you're really not following the original recipe. So this variant recipe is at an increased risk of not turning out a good cheesecake. This is purely because you've accumulated too many polymorphisms or too many genetic variants. So it's really the number that matters when you talk about genetic variants or polymorphism. What's different about mutations is that mutations are very specific. This would be a mutation. So you replaced a very vital part of that recipe with something completely different that completely does not belong in a cheesecake. You replaced cream cheese with guacamole. This, my friend, is not a cheesecake anymore. This is a mutated recipe. So this is what a mutation looks like. It's not a cheesecake anymore. It doesn't function as a cheesecake. You're really sure that it's not going to taste good as a cheesecake. Whereas for the other variant recipes, because there are so many possible variant recipes available in so many combinations and permutations, there's no way that you're going to be able to try every one of these recipes and taste for sure, okay, this is a bad recipe, that is a good recipe. It's the same with polygenic scores and genetic mutations. Polygenic scores look at the recipes as variants. So it looks at all the variant recipes, and it judges based on how they look whether the recipe is going to be good or not. It's an association. Genetic mutations are very specific. It's specifically you replace cream cheese with guacamole. You can totally test this recipe out and you can say for sure this recipe does not taste good. So if you have a genetic mutation, we have lots of evidence showing cause and effect that this mutation can cause heart disease, or this mutation increases your risk of heart disease. So this is how mutations are different from polymorphisms or genetic variants. And and there's lots of uncertainties with genetic variants, but less uncertainties when you have identified a specific mutation. I think Dr. Kramer was going to...
This is Dr. Guillaume Perret. So he's one of our heroes at McMaster. He spends his time in the genetic lab as well as working clinically. So I'm going to share some information he shared with the group here. So again, as Rachel is pointing out, most of the genes give you a little bit of change. And so if you change a lot of these associating factors, you get little bits of change in hundreds or thousands of genes. And this was actually taken from the GWAS catalog of over 130,000 associations. So this has actually grown over time, and this is still growing at this point in time. So if you look deep into your human genome and look at all these different associations, you can find more and more information. And basically, we found that 1,000 of these changes were associated with underlying traits. Next slide, please. So if you start to look at this, so we're going to talk about this on the top here, is that one in the 250 individuals, if we can figure out how to mute that person, then that would be great, leads to familial hypercholesterolemia, so a genetic specific gene defect where the Ldl receptor is not working properly. The Ldl receptor is very important for cholesterol metabolism, and if it's not working, that increases your risk of about 3.7 times the risk of having early heart disease. And we also, and that's present in our population, again, 1 in 250 people. We also found what Rachel was talking about, if you make guacamole with substituting too many of these variants, that 1 in 50 people have a high polygenic score, and they have the same risk, or 3.5 times, or 3.7 times the risk of developing early heart disease. So the first one is a single mutation that causes a problem, and the second is the interaction of hundreds of variants. They all contribute a little bit to cause heart disease, and it's much more common. And that's brand new information. And so we're now finding you can have single gene mutations that cause a problem, and more importantly, multiple gene traits that cause a problem over time. Now, this is actually very important to understand, is that when you saw my score for cholesterol and triglycerides, that was a concentration on cholesterol and triglycerides causing heart disease. Many polygenic scores, as Rachel was pointing out, we don't know what these genes do. They're associations. So you can have a low cholesterol and still develop heart disease. But what we're going to find out is that lowering cholesterol when you have high cholesterol is important, but lowering cholesterol in people with a normal cholesterol can actually be just as important, if not even more important, if you face a very high risk. So it's really important to understand why you have this problem, and if you don't understand why you have the problem, understanding how this is going to imply to your health over time. So this is very much a work in evolution. So this is very fascinating. And so let's go to the next slide. So I know this is a little bit confusing, but we're making great inroads. Again, this is the architecture of heart disease. So we know lots of things like high blood pressure, diabetes, smoking, overweight, all play a role. And the top 5 is don't get older, know your family history, know your blood pressure, know your cholesterol, don't smoke, don't be overweight, have good relationships. But we also realize that there's a much stronger, deeper look at the human genome as well that can play a role. And remember, just because you have either a specific genetic defect or you have a high polygenic score, it doesn't determine what's going to happen. You can change that. And to me, knowing what your strengths and weaknesses allows you and myself to be healthier. So well, that's something to think about. And so very, 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 very exciting information. And this, all you can see, this is the work in evolution. You can see, to do these gene studies, you need huge sums of people. Look at this, is that they studied 120,000 people that didn't have heart disease, and they looked at association to 60,000 people that had coronary heart disease to find these associations. And each of these variants contributes to a very small effect, but the totality of all this, the snowflakes causing an avalanche, the raindrops causing a storm, is important to look at that. So we're a mixture of all these above. So this is very exciting and very new information that will continue to evolve over time. Next slide, please. So what you saw from me was the information of my risk of heart disease based on cholesterol and triglycerides, but we weren't looking at the risk factors. And you can see this association. A number of years ago, there was a few markers, and now this is growing over time. So we're expanding at a very high level, and some of these associations will be causal, and some will not be. So this is really much a work in evolution. So most of us haven't used this information clinically, and we're going to start using this more and more, because wouldn't it be nice the day you're born knowing some of the risks that you're at risk for, let's say, breast cancer, risk for colon cancer, risk for Alzheimer's disease, risk of heart disease. Now, to some people that's scary. To me, knowledge is power, and what I need to do to overcome these effects. So to me, I want to know where I stand and how to change some of those variants and how to make things better. And so this is really, really new information, evolving information. Next slide, please. So we're going to get back to the cheesecake.
Okay. So we're talking a little bit about dominant and recessive mutations. So we're focusing on mutations. What we need to know is that each of us has 2 copies of the same gene. There's one from the mom and one from the dad. There's a 50% chance we'll get either copy of their gene. So the mom will have 2 copies of the genes and the father will have 2 copies of the genes. Under normal circumstances, if there's no mutations in your family, the 2 genes will be the same, and you end up with a pretty beautiful cheesecake. However, there are cases where there are mutations in the family. So this is called an autosomal dominant inheritance. In a dominant inheritance pattern, just having one defective copy of the gene is enough to cause disease. So it doesn't matter if you have a normal recipe, as long as you have a mutated recipe, you're going to turn out to be a guacamole. Oftentimes, if you have 2 defective copies, when you have an autosomal dominant inheritance, when you have 2 defective copies, it will be an even more severe form of guacamole. Thus, if one parent has the disease, meaning that they have 1 defective copy, there is a 50% chance that their children will also get the defective copy and thus get the disease. So this is a pattern of dominant inheritance, where just having 1 mutation, it will dominate the other normal copy of the gene and cause disease. If both parents, let's say both the mom and the dad, have guacamole recipes in their genes, then there's a 100% chance for sure that their child would get at least 1 copy of that mutated recipe, because it doesn't matter if they're getting it from their mom or their dad. As long as they got it, they will get the disease. And there's a 25% chance that the children will get a more severe form of the disease. In a recessive inheritance pattern, 2 defective copies are needed to cause disease. So if it's a recessive mutation, that means that when you get a mutated recipe, you have a backup that you can use. And if the backup is normal, you're okay. If only one of the parents is affected with the disease, meaning that they have 2 mutated recipes, there is 0 chance that their children will get the disease, because there's no way that the children can get 2 copies at the same time. They can only get 1 copy from the father and 1 copy from the mother. So the children will be cheesecakes for sure. However, the children will become carriers of the mutation. So that means they are carrying a mutation, but they're not expressing it. No one can tell that they actually have the mutation. But this mutation can be passed on to the next generation if they decide to have kids. And so, if in a situation where there's one parent that has the disease, having two mutated copies, and there's one parent that has 1 copy, one parent that's a carrier of the mutation, there's a 50% chance that their children will be a guacamole, that their children will get both mutated recipes and have no normal backup to go with. And there's a 50% chance that the children will become carriers. So they will have a backup copy from the mother, but they will get a mutated recipe from the father for sure, because both recipes are mutated. So 50% chance disease, 50% chance carriers. The problem with being a carrier is that most carriers don't even know that they have the mutation when they have recessive inheritance, because there's nothing, they're not feeling anything, it's not showing in any way, it's just a copy that they're carrying around. So there are times when 2 carriers will become parents, and when this happens, when each of them carries 1 mutation but they don't know, both parents are carriers of the mutation, there's a 25% chance that their children will get the disease, where they will get both of the mutated recipes. There's a 50% chance that they'll just become carriers, so they'll get 1 copy, 1 mutated copy and 1 normal copy. And there's a 25% chance they'll be completely mutation-free, where they don't get any mutated copies and they just get the normal recipes. So, and most of the time, they will be a cheesecake. And so it's actually very important to know your family history, because once you start graphing out all the genetic diseases or disorders in your family, you can actually see the pattern of autosomal recessive or autosomal dominant. And we'll have some diagrams to show you a bit later on. So we have two patients here, and these are pretty typical cardiology patients, 50 years old, and they have some borderline high blood pressure. They're coming to Dr. Kearney, they're saying, okay, should I be worried about my blood pressure? Should I be taking medications? And then Dr. Kearney asks about their family history. Patient A has a pretty prominent family history of heart disease. The mother had a heart attack at age 52, had mini strokes in her 70s. Father had a stroke at age 43, had a bypass surgery at age 60. Brother had angina, also heart disease, at 42, and another open heart surgery at age 50. And sister had a stroke at age 47. So this is the family history of patient A. Patient B with the same problem have a relatively benign, pretty benign family history. The mother had diabetes at age 74. That's a pretty old age to have diabetes. At that time, it's considered pretty normal or benign. Father, mild dementia at age 80. That's nothing out of the ordinary to be experiencing a bit of dementia at age 80. Brother is healthy, sister is healthy. So really, it doesn't take a medical degree to see which patient is at higher risk of getting heart disease. If you were the doctor, you would probably treat this patient more aggressively than patient B, because you can see clearly that heart disease runs in the family, and most of the people in his family or her family had already had a heart disease event by age 50. So this patient A is actually pretty lucky. He hasn't had a heart attack right now. So you'll be treating patient A very aggressively. The problem comes, so heart disease does incur a risk on how we assess the patient. If you have a maternal history of premature heart disease, so if your mother had heart disease before the age of 65, that's what we call premature cardiovascular disease, it increases your risk of getting heart disease by 60%. If your father had premature heart disease, so if your father had a cardiovascular event, heart attack, stroke, surgery, before the age of 55, that increases your risk of getting heart disease by 75%. As for siblings, if you have a sibling who had a heart disease, who had a heart event, it increases your risk of getting a heart event or cardiovascular event by 40%. So the bottom line is, having a family history of premature heart disease, meaning before the age of 65 for females or before the age of 55 for males, increases your risk of heart disease by 60 to 70%. That's very significant, and you want to know about that risk so you can take necessary precautions. A common problem...
That first patient you mentioned is that I don't need as you point out, you don't need a doctor, you don't need a polygenic score, you don't need genes. That person A is at very high risk for future cardiovascular events. And knowing the family history is very powerful. And you just told us how high that risk is. These risk factors, so the same risk factors in a person who has a very positive family history is very worrisome. So when you learn your family history, find out when your mother, your brother, or anybody in your family had a cardiovascular event. So they had angina at the age of 40 versus, they died at 80 from old age. If you had a heart attack early, like you said, for a male before the age of 55 for a male, or 65 for a female, in fact, the earlier it is, the higher your risk is. So if I see someone who's had angina or a heart attack at the age of 35, you are at very high risk. And you need to take that very seriously. Thank you for showing that, Rachel.
No worries. One of the common problems we encounter at clinic is that when we ask patients what their family history is, they're very vague about it. So patient A comes into the clinic, I ask him, what's your family history like? And he tells me, oh, my mom had heart problems, my dad had cancer, my brother had some kind of heart surgery, and my sister has some sugar issues. This is a very typical heart history, family history that we get from some of the patients because they just don't know much. They don't know the details of the family history. And all this information that I got, which isn't much, can go a lot of different ways. It could look like this. the actual history. The mom has racing heartbeats since age 60. The father had prostate cancer at age 70, which is benign, which is normal for this age. Brother had surgery for congenital heart defect at age 2. The sister had polycystic ovarian syndrome, which also causes sugar issues, diagnosed at age 29. So just looking at this, you don't really see cardiovascular disease running in the family. So just looking at this family history, you would say that patient A is not at a high risk of cardiovascular disease. For the same information that patient A gave me, mother had heart problems. It could be a heart attack at age 55, which is premature heart disease. Father had cancer. It could be a colon cancer at a very early age, at age 43, which means he should get screened 10 years before that. The brother could have had a cardiac bypass surgery, which is also a heart surgery, at age 46. And the sister could have diabetes type 1, diagnosed at age 12. If you just tell me my mother had heart problems, my father had cancer, my brother had heart surgery, and my sister had sugar problems, the doctor can't figure out what kind of a risk you're in because we don't have enough details on what exactly your family history is. So good family history includes the specific disease, not just heart problems, but is it a heart attack? Is it a congenital heart defect? Is it enlarged heart? And the age of onset or the age of diagnosis. So at what age did they get diagnosed with cancer? At what age did they have the heart attack? These are very important information to include when you give a family history, because this is the information that we use to calculate your risk.
So my father had a bypass operation at the age of 50. That's important information.
Yes. Okay. And I think Rachel? Other Rachel?
Yeah.
Is talking about pedigrees.
So this might be the first time anyone has seen a chart like this, or maybe you guys remember back in high school biology and remember having to draw these out, but this is something called a pedigree. So Rachel mentioned before there's certain ways that we can kind of illustrate our family histories to see a specific pattern. So this is an example of an autosomal dominant inheritance pattern. So if you look in the middle row right there, I labeled you, so everyone can pretend that's you. So if you look at the T, the circle is a female, square is a male, and if it's colored in black, that means you're affected or you're guacamole. So let's go ahead and pretend that by being affected, it means you had kind of like a high-profile cardiovascular event, like your cholesterol is sky high, or you had like a heart attack at an early age, bypass surgery at an early age, anything like that. But normally when people do use pedigrees, it's for like one specific condition, a specific genetic disease. But right now we're pretending that you had like a heart attack around the age of 50. So what a pedigree kind of does is it draws out the rest of like your family tree. Thanks, Rach. So all the lines connecting to the side, that's your sibling. So it's you, brother because it's square, and then on the other side there's your partner, and then your partner's siblings. And then if you go one level up, that's your parents' lineage. So you have your mother and your father. You can see here the father is also colored in black. So what this is kind of telling me is if you or me, I had the heart attack or surgery at an early age. And if I go up, my father also had a relatively high-risk event at a concerning age as well. My mother didn't have any conditions. And then my partner, or like your partner, didn't have anything. Their siblings don't have anything. Their parents didn't have anything. So you can kind of draw that out for your own family and your partner's family and see what that looks like when you color it in. And then what happens is then you can try to assess your children and whether or not the condition you have is like highly heritable or not. So you draw a line down, you have your kids. This person had 3 kids, and 1 out of 3 of their kids also had a similar type of cardiovascular event. So you can see here, like when you actually look at the picture in the whole, like say you're illustrating your family history and you're like, oh, like, yeah, like my dad may have had high cholesterol or a heart attack. Nothing on my mom's side, nothing on my partner's side. My kids probably were fine. But as you can see, for a lot of these conditions that have a high inheritance, high risk of inheritance, like autosomal dominant, sorry, my dog is having fun out there. It only really takes one person to keep passing along generation to generation and have one of your children affected as well. So this is actually, it might look complicated, but it's relatively simple to do. It's just circle or square. You color in whoever might be affected. I kind of recommend everyone try to do that on their own time, where we can help people work through it at the very end if they want to, and show us like your sheet so we can help you like really see it. And it might be kind of interesting for you to see how different conditions might appear in every single level of your family's generation that you might not have really noticed before.
So getting the family history takes some research. So we'll keep working on so spend the time, speak to family members. That's important. Thank you.
Yes. And it's also very important once you are able to trace back to your generations, you might recognize that someone else needs to be screened. So if you know that your children was tested for something, and that you have something, and that your father has something, if your father has any siblings, they should get tested too. And if your father's siblings had any children, they should get tested as well. So this is what we call the cascade testing. If you find someone with a genetic disease, you try to basically find out anyone else that's related and anyone else that can get the disease, and make sure that they're getting the correct treatment and that they're getting the correct attention to their genetic problems.
So one of the questions that popped up is, I have covered genetic testing at this stage. The answer, no, not for heart disease. And we'll talk a little bit about genetic testing, what's available, and the evolution that's going to happen over time. But right now, for most diseases, at least for heart disease, this is not something that's readily available.
Yes, but you do have some options of less expensive genetic testing. So nowadays, there are lots of self-serve genetic testing kits available to the general public. The most notable ones include 23andMe, you probably heard of, Ancestry DNA, or TellMeGen, and many other companies that offer genetic testing. Some things to keep in mind of the following when you choose one of these genetic testing kits is that, one, do they offer health screenings, or is it just ancestry testing? The three that I have listed on the screen here, Welcome to You and TellMeGen, they offer health screening. So they'll actually test your genes and they'll tell you if you're at risk of certain health or diseases. Ancestry DNA just tests for your ancestry or for your relatives, not for any health problems. So make sure you do enough research. Are you prepared for the possible results of the test? If you chose to test for health problems, are you going to be okay accepting a result that tells you you have a gene that's related to an incurable disease, that you're at risk of Alzheimer's, that you're at risk of breast cancer, and we don't really have any way to deal with it? Are you okay with knowing these results? Are you also okay with unexpected paternity results? Usually paternity is something that you have to opt in for, but there are people who opt in thinking that it will be fine, but come out knowing that their dad is not their dad. So are you ready for the unexpected results? If you do opt in for certain, services that these genetic testings offer. And also remember that these testing kits are not as accurate as a prescribed genetic test from a genetic counselor. So if someone who takes 23andMe and finds that in their report it tells them you have a BRCA mutation, that's a gene that's related to a high risk of breast cancer, they will probably want to go to a genetic counselor, and the genetic counselor often will say, okay, let's redo your genetic testing, because these testing kits are not the most accurate, and we'll try to find out for sure if you actually have the mutation. There have been cases where there are false positives, where the 23andMe or the other genetic testing that's available to the general public told them that they had a mutation that will cause disease. They went to a genetic counselor, they did the actual genetic testing from a lab, and it told them they actually don't have the mutation. So there are risks for false positives. There are risks for knowing something that can be very anxiety causing, and just make sure you do your research and make sure you think of the consequences and if you're ready to accept the results when you choose to do genetic testing.
So this is a slide that tells us a little bit what's happening now. We're going to talk about familial hypercholesterolemia, a very specific gene mutation. It's relatively more common in Quebec, roughly 1 in 100 people in Quebec through the founder effect, people coming over from France, certain communities that with some inbreeding at the time, is that they have much more prevalence called familial hypercholesterolemia, we're going to talk about. In Ontario, it's felt to be at around 1 in 250 individuals. Right now is that you can get the test done at Life Lab. It will cost you $1,500. Traditionally, gene testing was in the order of $5,000. The prices are changing, and now offering this for $500. This is a work in evolution right now. So this is actually going to be a big advance. For instance, if you have an LDL cholesterol above 5, that's a marker for, if you're an adult, a marker for genetic problems. And knowing your genes in this circumstance can be helpful. It does increase your risk an additional 3-fold. But anybody who has an LDL cholesterol above 5 in an adult is very worrisome. That should be treated very, very aggressively. And we'll hear a little bit more about, in younger people in that area. So this is a work in evolution. And what I like everything is that I'm learning all the time. And let's just move forward. Next slide, please.
Okay, so we talked about what genetics is, polygenetics, and how to get a hold of your family history. Why do we need to know all this? What effect does genetics actually have on heart disease? So genetics roughly contributes to about 1/3 of heart disease, 32 to 35%, depending on what sources you look at. And genes affect the risk of heart disease via various mechanisms, most of which we don't currently understand. And when we don't understand how they cause disease, that also means that we can't prevent it. There's no specific treatment for those gene variants or gene mutations. However, there is one subset of genes that operate on a pathway that we do have a pretty good understanding of. These are the genes that affect your levels of lipids in the blood, namely the cholesterol and the triglyceride levels. So this is a pathway that we do understand, and if a gene affects these pathways that in your blood lipids, then this is something that we can do about. We have treatments that will help lower your cholesterol. We have treatments that will help lower your triglyceride levels. So there's an enormous body of research behind the relationship between lipid levels, especially cholesterol levels, and cardiovascular disease. And there are also, as I said, many available treatments to reduce the risks associated with abnormal lipid values. So this is one of the presentations on PCME, and this is basically a modeling of cholesterol level versus age of heart attack. When you have something called homozygous FH, so a very severe form of a gene mutation, where you have 2 defective copies and you have very, very high cholesterol, 15 to 30 millimoles per liter when you're born, the modeling shows that you're probably going to have a heart attack between 3 to 6 years old. If you have heterozygous FH, this is a mutation where you only have 1 defective copy, and your cholesterol is a little bit lower but still quite high, 4 to 10 millimoles per liter. You probably will have a heart attack between 30 to 60 years old if you don't do anything about it. In normal individuals who doesn't have genetic mutations, their LDL level, LDL is lousy cholesterol, is between 2 to 3 millimoles per liter. So that's the normal range. And in the general population, if you have a low cholesterol, you probably won't get a heart attack until you're 80 years old or 100 years old, if you're able to keep your cholesterol low. There's also a type of mutation where it's a beneficial mutation. So it actually decreases your cholesterol. And from this modeling, we can probably predict that because of the beneficial effects of this mutation, they will have a heart attack later than usual, so at around 105 to 125 years old if they can live to that age.
So this is actually very, very important. So, because if you have a very low cholesterol in your lifetime, you can live to over 100. If you have a very high cholesterol, you can have a heart attack as early as the age of 2 years of age. And that's a very specific gene mutation. And right now in Ontario, 1 in about 200 to 1 in 250 individuals are walking around with a gene mutation called Homozygous Familial Hypercholesterolemia that will give you a heart attack on average by the age of 50 years of age if you leave it untreated. And we know from genetic studies that if you have a high polygenic score, your risk is higher, and that starting cholesterol medications early in life with a normal cholesterol with a very high or a very positive family history is very important. And so you can treat very aggressively later in life, or you can treat more gradually in life. So this is extremely important information. If you walk away with one message, take a picture of the slide. Also, make sure you know what your cholesterol values are, and take steps to know your risk. Now, you can see is that you may be a cheesecake or a guacamole, and you're going to have trouble understanding that. That's why we need experts. I spent my life thinking about this, and I'm seeing so many people whose lives end before their time. And I feel really sad when you can actually make this problem go away. You can make a person who has heterozygous familial hypercholesterolemia normal life expectancy. You can also take a person and potentially, by lowering cholesterol over a lifetime, either through genetically or through medications and lifestyle changes, potentially live over the age of 100 years of age if something else doesn't take your life away. Amazing what we can do. And I'm also totally amazed what people think they know and don't know. You can see this is complicated. We're learning a lot over time. But there are people out there that can help you with that. Take advantage of that and listen to them.
Sorry.
Go ahead.
So maybe we can take a couple minutes to answer a question that we had in the chat. So Joanna and Statins, they were wondering if genetic testing for cardiovascular disease is covered under OHIP. To my knowledge, genetic testing for these conditions that we're talking about, where you have high cholesterol or high lipid values, they're not covered. But the reason for that is because if you actually have a genetic condition that's causing you to have really high cholesterol, there's like a really easy way to see if your kids might have that, and that's to get your kids' cholesterol checked as well. All these genetic conditions, like Dr. Kearney mentioned and like Rachel mentioned, you're born with it, so you'll have high cholesterol levels from the day that you're born, and it's something that will present like really early in life. So Joanna and Satinder, if you feel like, or anyone else on this call, if you feel that your cholesterol levels are really concerning, or you had a doctor tell you that they were just really, really high, there might be some genetic risk towards your family member, the easiest thing and like the freest thing would probably just tell your kids to get their cholesterol checked as well. Ask your family doctor to get your kids' cholesterol levels checked as well the next time they get their blood done. There's no need to go through like expensive genetic screening for this, because you have like a blood work test that can pick it up.
Perfect answer.
Yes. Okay. Do we have any other questions before we move on?
I can think of a million of them, but we'll come back to that.
All right. So we'll start out with the case. So this case is about a 4-year-old boy who has a genetic disease. It's called homozygous familial hypercholesterolemia. So this is a disease where he had 2 defective copies of a gene that gave him a very severe form of the disease that causes extremely high cholesterol. His LDL cholesterol is 20 millimoles per liter, and normal should be below 2.5 or below 2, depending on what your goals are. Medications, unfortunately, was not effective in lowering his cholesterol, and he died suddenly at the age of 4. His main artery of the heart was 98% blocked off by cholesterol plaques. So this is what his artery looked like. You don't really see an opening here. It's not really a tube anymore. This circle shows you what should be blank. So there should be nothing in this circle, but you can see that there's all this plaque and gunk inside his artery, and a tiny sliver of opening. That's the 2% that's still open that allows blood to pass through. And obviously not enough blood because the boy died suddenly of a heart attack. So this is what can happen when you have extremely high cholesterol and it's not being treated effectively. So here's a scale of LDL cholesterol. LDL is your lousy cholesterol. Normal should be below 2.5 or below 2. When you're above that, you're considered to have hypercholesterolemia, high cholesterol. And common hypercholesterolemia that's not due to genetic mutations usually ranges from above 2.5 to a little bit above 5 if you have really high cholesterol. If you have a genetic mutation that causes familial hypercholesterolemia, and you have one defective copy, which makes you a heterozygous familial hypercholesterolemia patient, your LDL range, naturally, without taking medications, would be from maybe 4.9 to 5 to around a little bit below 15. So that would be where your LDL is at. You can see you're definitely not in the same range of someone who doesn't have a genetic mutation. So as Rachel said, if you're suspicious that you might have a genetic mutation that causes your cholesterol to be very high, the easiest thing is just to take a blood test. You can see very clearly which range you're in just having a cholesterol test done, because your range is not going to be in the same range as someone who has just common hypercholesterolemia. So if you have one defective copy, your range is from 5 to about 14. If you have two defective copies, that's a more severe form of the disease. It's called homozygous familial hypercholesterolemia. Your range of cholesterol values is from 13 to way above 20. I don't know what the upper limit is, but it will probably be very startling. So you can see that if you don't do anything about familial hypercholesterolemia, when you have a genetic mutation, you have four times the normal, or even actually 10 times the normal for this boy, 10 times the normal of cholesterol that's in your blood veins, that's in your blood vessels since you're born, so constantly poisoning your blood vessels for the duration that you're alive, versus someone who only developed high cholesterol when they're in their 40s or 50s. You've had 40 to 50 extra years of damage to your blood vessels. This is why you have early heart disease, because you've been receiving damage since the moment that you're born. And this is why it's very important to treat you early. So this is just an isolated case of a boy, an unfortunate boy, who had a genetic disease, very severe genetic disease, and he died before his time.
Yeah, if you go back that one slide, is that there's probably somewhere between 50 to 100 of these people in Canada. So it's a very rare event. But the heterozygous is somewhere around 1 in 200 of us have this gene mutation. And I think it's really important to realize there's a lot you can do. Cholesterol tends to rise as we get older. And people say, can I get my cholesterol too low? Well, you're born with an LDL cholesterol, if you're normal, between about 0.7 or about 0.5 to about 1.5. So we're born and we prosper with an LDL cholesterol between 0.5 to about 1.5 range. And that's very low. As we get older, the cholesterol goes up. Traditionally in North America, we say that a cholesterol of 5 is an average cholesterol. An average cholesterol kills too many of us before our time. But really important is that the LDL cholesterol is really important, and to note, LDL stands for lousy cholesterol. So, as rightly pointed out, gene testing is not needed for the vast majority of us. And in certain circumstances, it's important. And we'll come back to that a little bit later on. So know your cholesterol and know your family's cholesterol, know your family history is the key right now.
So now we're going to talk a little bit about what exactly are these mutations in the genes doing to cause you to have such high cholesterol. So when it comes to a lot of the genetic high cholesterol disorders, there's three main genes. One relatively main player, but it's rare, and then another one that's like a contributing side factor. So three main ones that we'll go through, starting at the top. So we have the Ldl Receptor Gene. So you've probably heard us say LDL so many times in this presentation already. So just to reiterate, that's your lousy cholesterol that's floating around in your blood. It builds up in your blood vessels and causes a plaque that leads to you having a heart attack. That's why it's so dangerous. Ldl receptor. It's a protein that's present in different cells, mainly on your liver. What it does is it kind of like catches the LDL cholesterol that's circulating in your blood and like eats it, so it removes it from your blood, kind of cleaning your blood out in that way. So you want to have a lot of LDL receptors present on your cells. So if you have a mutation in your Ldl receptor gene, what these patients get is a defective receptor where the receptor can't clean up the LDL from your blood as well, causing you to have an excess amount of bad cholesterol in your blood. And this is an autosomal dominant inheritance pattern, so that means that as long as one of your parents might have had a mutation, they have high cholesterol that's very, very high, and if you also got that gene from that one parent, then you also will have this condition. And then the next gene is the ApoB gene. So this is an apolipoprotein. It's just a particle that makes up different cholesterol molecules. So it makes up parts of LDL and also different types of cholesterol too. And it kind of helps to transport the cholesterol around the blood and deposit it into plaques as well. It's kind of like acting like a little transporter, shopping cart molecule, whatever you want to consider that as. And this also falls in autosomal dominant pattern. So someone who has a mutation in the ApoB gene, what it might look like is they just have an excess amount of this molecule in their body. So they have excess transporters helping to transport cholesterol and deposit it in their plaques, which makes them at such high risk of having heart disease. Another key player in the gene realm is Pcsk9. So what this actually does is it blocks the LDL receptors that we talked about before from being able to actually bind and eat the LDL cholesterol. So it's not actually interacting directly with the cholesterol, it's just blocking what our body's normal mechanism is to help clean up our blood, which then causes obviously a buildup or excess amount of cholesterol in our blood too if we have high levels of that. And again, that's also autosomal dominant pattern. So these top three genes are the main genes that are implicated, or patients with familial hypercholesterolemia will have mutations generally in these three genes. And then the fourth one there, LDLRAP1/ARH, that's a mouthful. This is essentially an adapter protein that interacts with the LDL receptor and can also cause a similar dysfunction to the receptor like the Ldl receptor gene. Sorry, can you go back? The difference with this one is an autosomal recessive. So this is a very rare form of familial hypercholesterolemia. I think in our research we found that it was around 1 in a million, 1 in 2 million range. But it means that both of your parents need to have had this gene and need to have inherited both copies of it to have this condition, which is why it's so rare, but it is present. And what that might look like is you might have really high cholesterol, but no one, like your parents didn't have high cholesterol, so like skip the generation, and that's why it's like a little bit tricky to catch. But it is rare, so it's not something that you should be super concerned about having right now. And then the last one we'll talk about a little bit more in depth at the end of the presentation, but there's something called Lp(a). It's a particle similar to LDL, also associated with inflammation as well, but just high levels have been associated with increased cardiovascular risk. And what we know about this, we don't know the exact inheritance pattern, but we do know that high levels of Lp(a) are inheritable itself. And around 20% of us have a high Lp(a) for reasons unknown, and that also correlates with a high cardiovascular risk.
Alright, so now we're going to move on to some specific genetic lipid disorders. Those genes, the LDL, the Pcsk9, those things are going to come up again, so you don't have to worry about remembering them right now. So we have 3 genetic disorders prepared for you today. There are familial hypercholesterolemia, familial hypertriglyceridemia, and familial combined hyperlipidemia, a mouthful, all 3 of them. Familial hypercholesterolemia, we'll call it FH, is caused by one mutated gene, usually. Various genes have been discovered to cause FH. We talked about 4 of them, and it can be detected at a very young age. Even when you're a baby, if someone takes your cholesterol and you have FH, they'll see that your cholesterol is very, very high as a baby. So this can be detected at a very young age. Familial hypertriglyceridemia, it also can be caused by the mutation of one gene. This lipid profile, it features very high triglycerides, not high cholesterol. So you can have very, very high triglycerides, but normal cholesterol, and that can be seen and detected from a blood test from when you're a child to when you're a teen. So you can also find out this condition at a pretty early age. In familial combined hyperlipidemia, it's a little bit tricky because it's associated with single gene mutations, which increase the susceptibility for you to develop hyperlipidemia, but that does not mean that you will have hyperlipidemia. And the tricky thing about this genetic disease is that you usually don't detect it. So when you're a child, when you're a teen, you actually don't have abnormal cholesterol or abnormal triglycerides. It will come up, it will flare up at random times throughout the course of life. Like when you're 30, you might suddenly get very high triglycerides, and then when you're 40, maybe suddenly very high cholesterol, and then maybe 50, you have normal lipids again. So it fluctuates a lot, and it's a bit hard to catch. That's familial combined hyperlipidemia. We're going to be spending a lot of time on familial hypercholesterolemia because that's the most common genetic disorder, and something that we can do a lot about because we have a lot of treatments that can target cholesterol. So this is a video that you can view at your own time. It's basically a patient story about this woman who, her father died of a heart attack when she was 15, and he died at age 39. She was diagnosed and she was told to take medications. But as you can imagine, a 15-year-old told to take medications for the rest of her life, there are times where she will fall off the wagon, and she did. She stopped her medication because she's like, I don't see it, I don't feel it, I'm fine. And then when she was 39 years old, she found a bump on her elbow, and she had to go to the dermatologist, had that taken out, and had it examined under a microscope. The doctor came back to her very worried. He's saying, this bump on your elbow, it's actually cholesterol. And if it's on your elbow, it's everywhere in your body. And this is very serious. And she had to get referred to a specialist clinic for cholesterol and lipids at Stanford. So this is her story about her journey with hypercholesterolemia, familial hypercholesterolemia specifically. And you're welcome to watch it at your own time. It's a very short clip.
So this is just an example of what someone's pedigree might look like if they have familial hypercholesterolemia. So let's see. If you start from the very top, this goes all the way back to my great-grandparents. So one of them was affected. They're circled in yellow. We have a great-grandmother who had familial hypercholesterolemia. It got passed down to their only child, it seems like. The grandfather also had familial hypercholesterolemia. The grandmother did not have familial hypercholesterolemia, if you look at the partner. And then when they had kids, so they had 1, 2, 3 kids, and 2 out of the 3 kids they had FH. And then one of the kids who did have FH married someone who did not have FH, and they passed it on to one of their kids as well. So you can really kind of see this 1 and 2, like 50% inheritance pattern that's going on. 2 kids, one of them had it. 3 kids, 2 of them had it. And at the very end, 2 kids, one of them had it. So if you do have this condition and if you kind of like draw it out and go back, it's very clear to see the relative pattern of inheritance. And then you can also kind of assess the risk that your kids might be. It's probably a 50% chance that one of your kids might have it if you personally have this condition. Alright, so why should you actually carry out familial hypercholesterolemia? So we talk a lot about why LDL is so dangerous. We said already it affects 1 in 250 people. The kind of scary stat about this is 50% of patients with heterozygous FH, heterozygous meaning only one of their parents had FH and you got it from them, will have a heart attack by the age of 50. So 50% by 50. It's really easy to say, but it's scary to actually understand and interpret that. And not only that, people with FH will have a 3 times higher risk of having a heart attack within 10 years for people who are treated, and then 20 times higher risk of a heart attack within 10 years for patients who go untreated. And this is compared to people who aren't non-FH patients with the same LDL cholesterol. So even at the same LDL cholesterol level, you're just at a much higher risk of having a cardiovascular event if you're gene positive, I would say, for this condition. So just a little talking about the variability within ethnicities, because some people are always like, oh, how do different ethnicities play a role, or should that be taken into consideration when we want to screen our kids, or yada yada. Overall, for FH, it presents relatively similarly across different ethnicities. Filipino populations in the study did have a slightly higher prevalence, 1 in 150, compared to the average, which is 1 in 250. But for European, African, East Asian, South Asian descent, it was all relatively similar, between 1 in 230 to 1 in 290. So that's something to take into consideration if you are a Latino population and you have high cholesterol, then this condition is slightly higher prevalence within the ethnicity. And then which mutations or which genes are mutated within each population also vary as well. That's just, again, something to keep in mind if you're curious about the type of mutation you have, but it's not actually super relevant in terms of the treatment, as we'll talk about in the future. And then if you look to the right there, this is just showing what LDL cholesterol levels look like in a non-FH patient versus an FH patient. So the light blue peak curve that you have, that's the non-FH patient. So we have dotted red lines for an LDL level of 3.5 and an LDL level of 5. And you can see that pretty much like 90-95% of that entire light blue mountain sits before LDL of 5. So that really falls in line with what Rachel was showing before, with the different levels of cholesterol and the different conditions that it comes to. So that's just the common population, no mutation. And pretty much a majority of the population is peaking before those really high cholesterol or LDL levels. If you look at the dark blue or like purple mountain in front of that, you can see here now a lot of that volume of the mountain is sitting past LDL level 3.5, past the LDL level of 5. So that's just showing you how this population of gene positive compares to the normal population, and how so much more of patients who have this condition will have very high LDL levels that normally are not seen.
So one of the things about gene positive is you point out or could make the diagnosis of this disorder the day you're born. People who have a so-called polygenic form will have a gradual rise over cholesterol. That's why the specific gene disorder causes a higher risk, because the cholesterol is high from the day you're born. Cholesterol tends to rise still as lifetime goes up, but you start off way behind with a very high LDL cholesterol. So this is important for me. Thank you.
Okay, so we're going to be going over some diagnostic criteria of FH for those who are interested to see if you're at risk or if you should get tested. This will be a very good section for you. So there are 3 criteria we'll go over. We'll start with the Canadian FH criteria. It's a simplified criteria. So when do you get suspicious of FH? You get suspicious when you're an adult above or older than 40 years old, and you have an LDL level above or equal to 5.0 millimoles per liter. That applies to most of us on the webinar here, I think. And if you are between 18 years old and 39 years old, then you get suspicious if your LDL is above 4.5. And if you're a child or a teenager below the age of 18, you get suspicious when your LDL is above 4 millimoles per liter. So these are the values when you should start thinking that maybe you have a cholesterol problem. And so there are certain steps that we take. So once you have a high cholesterol, you see if you qualify for any of the following criteria. 1, if you had a genetic test, or if you have a confirmed gene mutation, either in yourself or in a first-degree relative. So for example, you know that your mom has a genetic mutation. Or if on a physical exam, your doctor finds what's called tendons and bilmas. These are cholesterol deposits that are on your tendons. They kind of look like this. So these are tendons and bilmas on your knuckles. They can be on your ankle, back of your ankle. They can be on your knees. So these they'll feel very hard, very hard cholesterol deposits, and that will move as you move your joint or with your tendon. So these are 2 of the 3 criteria. Or if you just have a really, really high cholesterol, above 8.5. If you qualify for any of these 3 criteria, you have definite FH, according to the Canadian FH criteria. So high cholesterol, any of these 3 criteria that you qualify for, you have definite FH. If you don't qualify for any of these 3, there are what we call minor criteria. So these minor criteria include if you have a first-degree relative who also have high LDL. And by high LDL, we mean basically this criteria on top. If they're an adult, it should be above 5. If they're a child, it should be above 4. And in your first-degree relative. So if your mom also has a high LDL of above 5, and you also have a high LDL of above 5, then you have probable FH. Another criteria is if you have a personal history of early cardiovascular disease or a family history of early cardiovascular disease. And by early, we mean for women before the age of 65, for men before the age of 55. If you qualify for these criteria, you are also a probable familial hypercholesterolemia patient. So these are the minor criteria. The one we went over before is the major criteria.
What's a first-degree relative, Rachel?
First-degree relative is people you are immediately related to. So it could be a parent, it could be a brother or a sister, or it could be your child. So on that pedigree, the family tree that Rachel talked about, it should be people who are directly linked to you in some way. We could take a look, actually. Okay, so here, let's say this is you, right here. So people who are first-degree relatives are people who are directly linked to you, not including your spouse. So that would be your children, which are directly linked to you. That would be your siblings, which are also directly linked to you. And also your parents, so mom and dad, also directly linked to you. It is not your grandparents, and it's not your aunts or uncles.
Thank you.
Okay.
Aunts and uncles increases your risk. They're considered second-degree relatives.
Yes. So once you combine all these criteria, you get basically a process of exclusion or a process of diagnosis. So you have someone who's suspicious for FH. You see if they qualify for any of the major criteria. If they do, they have definite FH. If they don't, then you move on to the minor criteria. And if they qualify for any of the minor criteria, then they have probable FH. And if they don't qualify for any of the criteria that we talked about, then they probably have just severe hypercholesterolemia, polygenic. So they don't have a mutation, but they probably have genetic variants that's causing their high cholesterol.
Plus diet and lifestyle changes.
Yes, that as well. Don't forget lifestyle changes. So this is the Canadian FH criteria. It's pretty simple. You go through the route, and then you see if you qualify for any of the criteria. The next one we're going over is called the Dutch Lipid Clinic criteria for FH. This is pretty straightforward as well. It's basically ticking off boxes and doing some math. So each of these criteria, if you qualify for it, will give you a certain number of points. At the end, you add up all your points, and your diagnosis is based on the total number of points that you have. So for definite FH, you should have more than 8 points. Probable FH, 6 to 8. Possible FH, 3 to 5. And unlikely FH if you have less than 3 points. So basically that means if you just have a little bit of a high cholesterol and maybe you have premature peripheral vascular disease, you don't really qualify for FH. You need to have higher cholesterol, you need to have some physical findings if you have it, some family history if you have it. A combination of all these will give you a definite FH diagnosis. Other than, of course, you could just get a genetic testing done. So this is the Dutch Lipid Clinic criteria. It's the point system. The Simon-Broom criteria for FH is very similar to the Canadian criteria. Again, there is a certain point where you get suspicious of people who have FH. So total cholesterol above 7.5 or LDL above 4.9 if you're an adult. Total cholesterol above 6.7 or LDL above 4.0 if you're a child that's younger than 16 years old. You go through, again, the criteria. There are criteria for definite FH where you have physical findings of tendons and bilmas, either in yourself or in a first degree or a second degree relative. So basically your whole extended family, if anyone has tendons and bilmas, the cholesterol deposits on their tendons that we saw in the images before, then you have definite FH according to this criteria. Or you could just do a DNA test and see if you have any of these mutations that we talked about, so the Ldl receptor, the Pcsk9, the ApoB, and if your genetic testing comes back showing that you have a mutation, then you also have definite FH. For probable FH, it's based mostly on family history. So if you're suspicious for FH because of your cholesterol levels, and you look at your family history, and your family history shows that you have early cardiovascular disease in your first degree or second degree relatives, then you have probable FH. If your family history shows that there is high cholesterol in a first degree or second degree relative, depends on what age it is, there's different criteria, then you also have probable FH. So all of these criteria you can see, family history makes up a bulk of how a doctor decides whether you have FH or not. So it's very, very important that you get a clear family history in your hands when you go to the doctor so that they can actually use the information to help you assess your risk and to help make a diagnosis. So we talked about FH a lot, and we said that FH is caused by one gene mutation. So that's what we call monogenic. Mono means one, genic means genes. FH is monogenic because it's one gene mutation. Polygenic hypercholesterolemia is high cholesterol caused by gene variants, so lots of different genes together. And there are some differences between them. For monogenic FH, again, it's caused by one mutated gene. It's often inherited from one of the parents. In polygenic hypercholesterolemia, it's caused by a combination of several or many faulty gene variants, and they're inherited from both of your parents. In monogenic, this one mutated gene is responsible for a significant increase in LDL levels. We saw that the 4-year-old boy who died of a heart attack at age 4 had 10 times the normal amount of cholesterol. In polygenic hypercholesterolemia, each little gene variant only increases your LDL by a tiny little bit, and it's all of them together that actually increases your cholesterol to a noticeable amount. In monogenic FH, the parent who also has the mutation will also very likely have high cholesterol levels. With the exception of if it's a recessive inheritance pattern, then your parent may not have high cholesterol levels because they're just a carrier, they don't have the disease. But in most cases of FH, because most cases of FH are dominant inheritance patterns, if you have high cholesterol levels, it's very likely that one of your parents also have high cholesterol levels. It's not really the case for polygenic high cholesterol because, again, we're talking about gene variants, and it's the number that matters in gene variants. It's how many gene variants you've accumulated. So your parents may very well have normal cholesterol levels because they haven't accumulated enough variants to actually affect their cholesterol. It's only when it came to you, when the two of them combined their gene variants together, that you got enough faulty variants to actually cause a noticeable rise in your cholesterol levels. So when you look at the family tree, at the pedigree, you'll see the pattern of inheritance in a monogenic hypercholesterolemia, but you likely won't see a clear pattern in polygenic hypercholesterolemia. And last but not least, very important in terms of clinical treatment, for monogenic familial hypercholesterolemia, if you don't treat it, you are 20 times more likely to get early heart disease than someone who doesn't have this disease. However, for polygenic hypercholesterolemia, it's usually less risk than having a genetic mutation. So variants, compared to someone who has a genetic mutation versus someone who doesn't have a specific mutation, but just genetic variants, when you have the same cholesterol value, someone who has a mutation will have a bit of a higher risk.
Okay, so we're going to move on to familial hypertriglyceridemia now, which is another type of lipid disorder that's specifically characterized by the overproduction of very low density lipoproteins, or VLDL, from the liver. And because of this, the patient oftentimes has an excessive number of triglycerides and VLDL on their lipid profile. And what VLDL is it's very similar to LDL cholesterol, like we said, lousy cholesterol. So it's also considered one of the bad forms of cholesterol. So even although like familial hypertriglyceridemia is commonly associated with an autosomal dominant inheritance, it's important to note that in some cases you might actually have a polygenic inheritance, where it's controlled by 2 or more genes, like Rachel was saying. So additionally, this disorder is also typically accompanied by other conditions where we see that the individual is either dealing with obesity or hyperglycemia or even hypertension. And a common mutation that's usually implicated in the development of this disorder is a mutation of the Lplg. And this makes it difficult to hydrolyze the triglycerides that are found within the VLDL core. And this is essentially what leads to the overall buildup of the triglycerides and VLDL that you find in the individual. And so the severity of triglyceride levels, it varies. Normal amounts are usually considered to be less than 175 milligrams per deciliter, but anything above that is usually defined as hypertriglyceridemia. But the severity also varies with your gender, your age, hormone use, and other dietary factors. So it depends on a lot of different factors as well. The image on the right, so this image compares lipemic plasma to normal lipidemic blood. So the sample on the left in the picture, it comes from a patient whose fasting total cholesterol result was about 14.2 millimoles per liter, and the triglyceride concentration was 41.8 millimoles per liter. So you can see in that sample on the left that it's a lot cloudier and it looks thicker too. And what this means is that the excessive amount of cholesterol and triglycerides in the blood are actually making it kind of like syrup, and this is making it hard for the heart to actually pump the blood. So the heart has to work harder to pump the blood in an individual like this. So that's something to keep in mind. Okay, so if you're not sure about your family's medical history, as we've all continuously mentioned now, it's extremely important to know what your family's history is like. And if you don't know about it, but you suspect that you may have hypertriglyceridemia or hypercholesterolemia, and you haven't gotten a chance to get around to a blood test or a genetic test, it's important to ask your parents these 3 questions that are outlined on the slide. And once you do this, you should go tell your doctor the answers to these questions, because the information could hold clues about your chances of having high triglycerides, which could be caused by an inherited disorder. So knowing this information will really help your doctor determine whether you actually need treatment or not and what type of treatment you need. So after you do this, your doctor will probably ask you to take a blood test, which is the cheaper way to go, rather than doing a genetic testing, as we mentioned. So once they take a look at that and we get an idea of what your blood triglyceride levels are, you can work with your doctor on the next steps. So when it comes to treating this disorder, you can work on lowering your triglyceride numbers through like daily activities and daily habits and medication if absolutely necessary. But essentially the goal of the treatment is to actually get your conditions that are raising these triglyceride levels, getting them under control. So this could include controlling your obesity or hypothyroidism and even diabetes. So some simple steps that you can take that may actually help you are losing weight and cutting back on sugar. It's been found that weight loss of even 5 to 10%, just a small amount of weight loss, can actually reduce your triglycerides level by about 20%. And regular aerobic exercise can also reduce triglycerides by 10 to 20%. So it has a really big impact on what happens to your triglyceride level, so that's something to consider and keep in mind. You'll also want to stop alcohol consumption. So if you're drinking too much alcohol, this usually causes your triglyceride levels to rise even more so than normal. And in some people, even a very small amount can raise triglyceride levels drastically. So generally, an average person who's not affected by this disorder should be limiting their alcohol consumption anyways. But if you're more prone to this problem because of your genetic basis, then you need to be even more aggressive with the interventions that you take and the treatments that you take. So this means that compared to an average person who's only limiting their alcohol consumption, you need to completely stop it. You need to avoid alcohol completely so that it has a better effect long term on your body. And similarly, smoking cigarettes is also really harmful for your body and can also raise your triglyceride levels. So if you have this condition, you should aim to not smoke. So even more so, yeah.
So a little comment here is that, so if you go back one slide, when you spin down the blood, it should be yellow. If it's white, you say you have this cheesy, syrupy constituent to it. That means your triglycerides are greater than 10. And if your triglycerides are greater than 10, you're at risk for a disease called pancreatitis, which is severe abdominal pain. It can actually turn into hemorrhagic pancreatitis. You can actually die from this condition. And if you have repeated insults of pancreatitis, the pain can get worse, you're very sick, and it's a progressive process. So not all people with triglycerides over 10 will get pancreatitis. In fact, the vast majority will not. But having a triglyceride where your blood is white when you spin it down compared to what's supposed to be yellow is a very serious condition. And this is actually, as you point out, if you go to the next slide, is that lifestyle changes are extremely important in this circumstance. They can have a dramatic change. And the first thing is that you mentioned is that if I have a triglyceride problem, no alcohol means no alcohol. Because it can rise very, very quickly and aggressively, and it can be potentially very serious and fatal. And so I think of all the white foods, white sugar, white flour. Those are foods that are the simple carbohydrates that can contribute to your body, can transform very quickly into triglycerides. A normal triglycerides is a value less than 1.7. I ran off the numbers, so less than 2. So it's really important to know these values and to treat them as you're pointing out. So thank you very much for sharing that. Keep going, thank you.
Yeah, so as, can we go back? Yeah. So as Dr. Kearney was mentioning, that lifestyle changes have such a big impact, and one of the biggest impactful lifestyle changes that you can make are to your diet, because they're so important when you're trying to lower your triglyceride levels. So in terms of your diet, you should really try to eat more fruits and vegetables, whole grains, and omega-3 fatty acids. And omega-3s are actually fats that are essential for your body, and they're typically found in certain fish like salmon or herring or albacore, tuna, or even sardines. And if you're vegan or not a meat eater, then you can find plant sources for these omega-3s, which includes walnuts or even flaxseed. And researchers actually found that at a dose of just 4 grams per day, omega-3 fatty acids were actually able to lower triglycerides by 20 to 30%. That's a drastic increase. So it's really important to change your lifestyle and make better decisions for yourself. And more importantly, change your diet, because that's one of the first things that you can do to help yourself. Yeah, we can continue on to the next slide.
Cholesterol is hard to change by diet. Triglycerides is very easy to change by diet and lifestyle changes.
Right. So some important data to really consider that kind of reminds you why you should take this seriously and why this matters is that this disorder has been found to affect 1 in 500 people. So that's just some stats for you to consider. And then something else to consider is that when triglyceride levels rise above 1,000 milligrams per deciliter, there's actually a 5% chance or 5% risk of you developing pancreatitis than normal people. And then this risk factor actually doubles when these levels reach more than 2,000 milligrams per deciliter.
So milligrams per deciliter are the American units. We use millimoles in Canada. So you just have to divide by 90 to get a value. So let's say a triglyceride of 1,000 milligrams per deciliter just corresponds to roughly around 10. Not quite, but I just sort of round off the numbers there. So it's important to realize there's always different units to look at that. Thanks. Keep going.
Yeah. So data from the National Health and Nutrition Examination Survey also showed that researchers estimated in adults with triglyceride levels that are greater than 150 to 500 milligrams per deciliter, the mean 10-year risk for atherosclerotic cardiovascular disease is 6 to 15.6%. Additionally, patients with hyperlipidemia are also at extremely high risk for developing premature coronary artery disease, and this is really helpful. And then, so this risk is about 30% greater than the average person. And if the disease is inadequately managed, the prognosis is really poor, especially if other cardiovascular risk factors are also present. And lastly, considering that higher serum triglyceride levels tend to usually be associated with increased risk of cardiovascular disease, someone with familial hypertriglyceridemia is at 2 times the risk of developing a cardiovascular disease than an average person because of their genetic predisposition to producing excessive amounts of triglycerides. So what this means is that this individual has been exposed to elevated triglyceride levels since birth, which is only increasing their likelihood to actually develop a cardiovascular disease. So you're more prone to cardiovascular disease because of this genetic predisposition that you have. We can move on to this.
Okay, so familial combined hyperlipidemia is one of the most common genetically determined hyperlipidemias in the general population, with a prevalence of around 1 to 2%. And it's also the most frequent in patients affected by coronary heart disease, with a prevalence of around 10 to 15%. So far, variants in 4 genes have been identified to cause this disorder. They include the LDLR genes, which we talked about, which is the most common, and STAT1, ApoB, and Pcsk9. And it's largely believed to be an autosomal dominant mode of inheritance. And the disorder itself is characterized by an increase in cholesterolemia and or triglyceridemia in at least 2 members of the same family. Also increased risk of coronary heart disease, and and it's estimated that around 10% of premature coronary artery disease is caused by this disorder. And you can also see high levels of very low density lipoproteins and or LDLs, and some can also have HDL levels and elevated apolipoprotein B levels.
Sorry, so we mentioned Lp(a) at the start of the presentation a little bit. Like you said, it's kind of like a contributing player to this whole high lipid, high cholesterol profile that someone might have. We talked about LDL, we talked about triglycerides, Lp(a) is like another one. So what this molecule does is it increases the risk of heart attack and stroke. It speeds up the plaque building process and makes the blood easier to clot as well, which is what contributes to the stroke. And it's not really something that a lot of people think about when they think about cholesterol. They think about like LDL, they think about HDL, they think about triglycerides, but Lp(a) has been one of those that if you come in with like a really high cholesterol panel, it's something that we also test on you as well. And at a level above 350 equals high risk. So we have Dr. Kearney's Lp(a) results back from 2004. And he definitely fits within that high-risk profile of 800 in September and 831 in March. How do you feel about that, Dr. Kearney?
Well, is that I thought I was okay when I found out that my triglycerides were a high polymorphic score. My cholesterol was a high polymorphic score. Then I found out at the third hit that I have a high Lp(a). This is something totally different. And you mentioned about 20% of us or so have a high Lp(a). So I have the dream team for heart disease when it comes to lipid profile. But I surrounded myself with the best preventive strategy possible, and I've been able to control this genetic problem. I can't change my Lp(a) at this point in time. There's research with drug therapy in the meantime, but more importantly, I'm getting my LDL cholesterol to as low values. I'm of the feeling that LDL cholesterol is a bad cholesterol. It stands for lousy cholesterol. It serves no good purpose except to kill you and cause atherosclerosis. All cells in your body can make its own cholesterol except for mature red cells. So you really don't need LDL cholesterol. It's still a controversial area, but we've learned that the lower the LDL cholesterol, the more the benefits are. And we've gotten lower over time. So I'm pretty excited that I've done a good job at working hard on prevention. I'm applying lifestyle changes and appropriate medication. So you only need to measure this once. I just confirmed this on a second value to make sure this wasn't a lab error. It's not a lab error. You can just measure it once in your lifetime and decide whether or not that that's an appropriate risk factor. And in a number of years from now, we have specific therapies to target Lp(a), so we'll more about this. So I've been proactive for quite some time, and I hope you take that nod in that right direction too as well. What do you think, Rachel?
Yeah, I think those are all really good points. Like we said, we can do some of LDL, we can do some of the triglycerides, Lp(a), not something that we can do right now if you do get tested. And I think it's just important to understand that, I also might have a high Lp(a). I never got tested myself, but 1 in 5, that's not a small chance for me to have it or not.
So people that should be tested is those people that who have a very early family history or multiple family members with heart disease or recurrent cardiovascular events, or you can't explain them by the conventional risk factors. So there's where Polygenic can help you, and there's where Lp(a) can help you too as well. There's other causes too as well that we're learning from: inflammation, C-Reactive Proteins. So we got a lot of things to work on and a lot of fronts to work on. So I have my C-Reactive Protein, which is a marker of inflammation. Mine is naturally quite low, and that quite low is partially because of exercise and partially some genetic factors as well that can play a role here. And I remember when you measured your cholesterol, Rachel, you were a little surprised to see that it was a little bit high, and you're taking some steps to make a difference in that. So, is that I think, as Rachel points out early on, if you don't want to know your risk and you're not prepared to deal with the consequence and it's just going to worry you, then don't do it. On the other hand, I know my risk and I know what I need to do, and I'm doing it to the best of my abilities, and I'm getting better at it. And I'm having fun doing it, and I'm also learning a lot along the way. So, and I'm glad we're able to share this with everybody. What else do you have to tell us?
All right, so we talked about bad genes, a lot about bad genes, but what can you do with bad genes? Dr. Kearney's done a lot. He's biking, he's playing tennis, he's being late to his daughter's soccer game, and he's eating healthy, trying to eat healthy, trying to cook, doing a lot of things, including taking statins to treat his bad genes. So what can we do when we have genes that are not that desirable? Good news is that you're not doomed if you have bad genes. There are things you can do about it, especially if it's concerning cholesterol. So here you see a graph, and we'll break this down for you. So we have 3 columns here. The first column is low-risk polygenic risk score. So these are the patients with very desirable gene variants, and it puts them at a baseline low risk for cardiovascular disease. In the middle, you have average risk. So this is the population average polygenic risk score. These people have basically in the middle wishy-washy risk at baseline for having cardiovascular disease. And on the third column here to the right, you have high-risk polygenic risk scores. These are the people who have undesirable genes, and that puts them at a baseline from the moment that they're born at a high risk of coronary artery or cardiovascular events. So these are the 3 columns. The different colors are different interventions. So you can choose what to do with those genes. You can choose to be green, to have a low LDL and a low blood pressure over a lifetime, and you're probably going to be at a very low risk. So this column here, the vertical axis, is your lifetime risk of having a coronary event, like a heart attack, by age 75. For someone who's at low risk, who also takes very well care of themselves, who has low cholesterol and low blood pressure, they have less than, let's say, 3%. 3% risk, lifetime, of having a heart attack. For someone who has average genes, they have maybe 4%, 5% likelihood of getting a heart attack. Even if you have very high risk polygenic scores, if you control your cholesterol and your blood pressure, you're still like less than 10% risk of getting a heart attack in your lifetime. This is probably around 5 or 6%. So even if you have very high risk genes, if you control your cholesterol and your blood pressure, your risk factors, you're still at low risk overall of developing heart disease. On the other end of the spectrum, if you're red, if you choose to be red, if you choose to not care about your cholesterol, not care about your blood pressure, and you let your cholesterol be high, you eat all those hamburgers and pizzas, you eat all those salts, and don't exercise. If you have high cholesterol compared to the population average, even if you have low risk polygenic score, good genes, there's still 20% chance of getting a heart attack in your lifetime. The risk goes higher when you're an average gene. When you have average genes, 30%. And when you have high risk and you don't take care of yourself, you have about a 45% chance of getting a heart attack by the age of 75. So there are a lot of things that you can do to decrease your risk. And the thing is, having bad genes doesn't mean you're stuck with heart disease. And we just looked at this graph. We know that controlling risk factors such as cholesterol and blood pressure, and this is just cholesterol and blood pressure, there are so many other factors you can control for, you can do much better than people who have good genes. So if you have bad genes, but you're controlling your blood pressure and your cholesterol, you're in the green zone. Compared to someone who has good genes, but not controlling the blood pressure and cholesterol, you're at a much better place. You're probably 3 times less likely to get a heart attack than someone who has good genes but not controlling anything. So that also means if you have good genes, it does not give you a free pass to chips and cola. You still need to have a good lifestyle for those good genes to actually work their magic. If you don't have a good lifestyle, if you don't control your risk factors, those good genes don't really do much in protecting you from heart disease. So then Rachel's going to talk about some of the guidelines we have in terms of controlling those risk factors.
Yeah, so this is coming from the 2016 Canadian Cardiovascular Society for Dyslipidemia treatment. So if you fit to any of those categories on the black box, so if your 10-year risk of having a heart attack is 10 to 20% or greater, it doesn't take a lot for you to hit 10%, by the way. I think I plugged in some numbers on calculator before, like if you're at the age of 50, male, non-smoker, at the mild blood pressure that's being treated with medications, and a pretty moderately high cholesterol level of 6 with an HDL of around 1, which is 1.1, which is not uncommon in that age group. And that puts you at around 9% risk. So any higher cholesterol, higher blood pressure, smoking history, older age will definitely get someone above that 10%. And obviously having a genetic cholesterol problem and much higher cholesterol is going to get you to 20% plus. If you fit into that category, if you have any atherosclerotic disease, so if you had any bypass surgeries in the past, maybe stenting, peripheral vascular disease, if you've been told you have any of those, if you're above the age of 40 and you had diabetes for 15 years or more, or chronic kidney disease, then you should be treated to reduce your risk of developing heart disease. And by treatment, the guidelines that we're targeting is getting your LDL cholesterol very low. So by low, we mean less than 2. That's kind of the guideline that we have right now, but we do know that lower is better. So LDL cholesterol 0 will be better than an LDL cholesterol of 1, which is better than an LDL cholesterol of 2, which is better than an LDL cholesterol of 10, etc., etc. But less than 2 is kind of the cutoff, or a greater than 50% reduction in cholesterol from your starting value. So let's say you start at LDL cholesterol of 5, and getting that down to 2.5. That's still kind of hitting the guideline and the target. Ideally, again, lower is better, but that's some target that we want to hit at if you're starting at a very, very high LDL cholesterol level.
So that's interesting. That's the guidelines for 2016 in Canada. The Canadian guidelines are coming out again this year. The American guidelines and the European guidelines came back out last year. I kind of like the European guidelines, and they suggest that in very high-risk people who had more than one cardiovascular event, especially in a period of a couple of years or less, aiming for an LDL cholesterol less than 1 should be our target. So you can see there's a moving target. So our targets are getting more aggressive for LDL cholesterol. And what I've also learned is that the polygenic score, you can have a very low cholesterol and still be at very high risk for heart disease, because you can have hundreds or thousands of genes interacting a little bit, very little to do with cholesterol that can lead to heart disease. And knowing that you have a very positive family history means that you should be more aggressive in your management of all risk factors, such as blood pressure, smoking, exercise, diet, and cholesterol. What I learned is that lowering LDL cholesterol from very high to very low is important, and also knowing your risk. Now, in my case, it's nice to have this genetic sampling, but I don't really need it. Look, a doctor came to my dad 40 years ago before gene testing. That's when the old family doctor came to my dad's house and said, "Listen, sir, you didn't come for your follow-up. I came to your house because you have one of the highest triglycerides I've seen and a very high cholesterol. I'm worried about you." And ever since that, he's changed his ways. Not as much as I'd like to see, but he made some changes. And so, while gene testing is very nice and elegant, you don't need it for most of us. And the best gene testing is still your family history, was pointed out, and just knowing your numbers and knowing your family member is so important. Where we need to get more information is when we're confused. You have a very high LDL cholesterol. And LDL cholesterol above 5 is very scary to me. Let's say the family history is negative, or it's unknown, and there's no early heart disease. That's where things like Lplg, C-Reactive Protein, and gene testing and polygenic scores make a role. I've seen so many people who have normal everything and still have heart disease. I now know the answer right now is probably they have a very high polygenic score we just didn't know about. You can see we're learning all the time, and the final answers aren't out, and we're still a long ways to go. So keep going, Rachel. You're teaching us a lot, and we're learning all the time.
All right. So in terms of lowering your cholesterol, you probably heard Dr. Kearney talk about statins a lot, probably every single webinar. So statins, there are many different types. We went over these during our hypercholesterolemia webinar as well. So we have the high-intensity statins, which are the atorvastatins and the rosuvastatins. They're all called Lipitor and Crestor, other brand names, easier to pronounce. You may also be on a weaker statin, a low-intensity statin, pravastatin, simvastatin, lovastatin. These are all different types of low-intensity statins. When you have a genetic cholesterol problem, you should be on a high-intensity statin, because high-dose, high-intensity statins can reduce your LDL by 50%. And for a moderate dose, high-intensity statin, it can still reduce your LDL by 30%. So that's a lot of efficacy in reducing your cholesterol. And you want that when you have a genetic cholesterol problem. An effective statin regimen will halve your risk of a heart attack or stroke. And there's only a small chance of it causing any muscle symptoms. If you have questions about muscle pain on statins, you can take a look at our hypercholesterolemia seminar. We went into it in a little bit of detail. We urge you to weigh the pros and cons carefully, responsibly, and honestly before stopping your statins. Is the muscle pain really caused by the medications, or are you just getting pains and aches from life? Are you really prepared to accept the consequences of stopping your statins? Like, are you ready to get a heart attack when you decide to stop your statins? You need to think about these when you decide to stop statins and you have a cholesterol problem. And what is an effective statin? For high-risk patients, so those with genetic hypercholesterolemia, an effective statin regimen is Lipitor, 80 milligrams a day, and Crestor, 40 milligrams a day. There is another medication that are usually added on to statins for patients who are not able to reduce their cholesterol enough to lower their risk. So this is called Ezetimibe. Ezetimibe is a different medication that works a bit differently from statins. So statins work in your liver, mostly. Ezetimibe works in your intestine. So the normal processing of cholesterol, the dietary cholesterol that you eat, is that your intestine absorbs those cholesterol, and that LDL cholesterol from your diet is going to be transported into your blood vessel. We don't want that to happen because we don't want extra cholesterol. So what Ezetimibe or Ezetrol does is that it prevents this cholesterol from entering your bloodstream if they're coming from your diet. And so that reduces your LDL by an additional 15% on top of the maximum statin therapy we just talked about. So statins, Ezetimibe, these are the gold standards in your first-line therapy of cholesterol-reducing medications. Now, if you're on both of these medications and you still can't control your cholesterol, or you're still at a high risk for cardiovascular disease, you have FH, you've had a previous heart attack, there's another medication that we can use. This is called a Pcsk9 inhibitor. And this is no longer a pill, it's an injection, it's an antibody. So this also works in the liver. So your liver, under normal circumstances, as Rachel talked about, it will eat up the LDL cholesterols in your blood with the LDL receptors. So that the liver cleans up the blood vessels of LDL molecules. However, in your bodies, you produce molecules called PCSK9. And these PCSK9 molecules actually interfere with the liver's eating process of the LDL cholesterol, so they prevent the liver from eating up LDL cholesterol. And that's bad because when you have a genetic cholesterol problem, you want the liver to be cleaning up your cholesterol as much as it can. But these PCSK9 molecules are preventing that from happening. So the Pcsk9 inhibitors, these medications, stop these molecules from interfering with the liver. So your liver can go back to cleaning up the LDL cholesterol, and that's how these medications work. So these medications are actually pretty powerful. They can reduce LDL by 50 to 60% on top of statin therapy. So that's the same extent of being on a high dose, high intensity statin. Unfortunately, this drug is not for everyone. There's limited coverage by the government for this therapy, and there are narrow criteria you have to meet in order to qualify for coverage of this drug. If you do pay out of pocket for it, it would cost several thousands of dollars a year. What is it now, Dr. Kenny, like $4,000?
The retail price now in Canada is $7,000, but you can get deals down to about $3,500. So still very expensive, but the price is sometimes negotiable. I hate to say that you have to negotiate the price of a medication, but that's something we can talk individually if you need to. It's one of the wonder drugs that we can't afford at this point for a large group of people. There are new drugs coming up on the horizon. There will be injectable drugs twice a year in the near future, and I'm told that they're going to be priced more favorably. So we'll see what happens. The price has gone down in the States and Europe. The price in Canada hasn't changed dramatically right now, but it's an expensive drug, but it's a wonderful drug. If I have my heart attack tomorrow, I'm going to go on it because I can afford to be on it. For the average person, it's not affordable, and I put money in the bank for that for later. So I have this genetic problem, so I have to work hard at that. But lots of options and more options to come.
Mm-hmm. Okay. There's a summary of the medication recommendations. Can everyone hear me? Sorry, that was a noticing when my phone was working. But just a summary of the medication recommendations from the 2016 guidelines. So patients having a high risk of cardiovascular events, they require an optimized effective medication regimen. That often looks like a high dose of a strong-acting statin. So that could be Lipitor 80 milligrams a day or Crestor 40 milligrams a day. Those two doses for those specific medications are kind of considered to be equal, with the addition of the side player of Ezetrol 10 milligrams a day. And in addition to the medications, they recommend maintenance of healthy lifestyle, which incorporates healthy eating habits. So people can look up the Mediterranean diet if you want an example of like a family diet that's evidence-based to be cardiovascular disease, lower the risk of cardiovascular disease, and also exercise. So the amount of minutes they want you to hit for that is 150 minutes of moderate to vigorous aerobic activity a week. It doesn't have to be all at once. You can do it in small bursts. If anyone has a step counter, another thing that you can try to aim for is around 10,000 steps a day. That's just another way to mark the amount of exercise you get. So that just brings us to the end of the presentation. So we just want to remind everyone of the key takeaways. The genes you're born with can increase your risk of developing various heart conditions, including cardiovascular disease. And then some conditions are more straightforward, where it's caused by mutation in one gene with a clear inheritance pattern. So we're talking about the familial hypercholesterolemia, and the familial combined lipidemia subtypes, and the familial hypertriglyceridemia. Some people's genes aren't as straightforward, so this is like Dr. Kearney, and we have multiple contributing factors that increase your overall risk of developing cardiovascular disease. So that's when we talk about polygenic risk source. Patients with high cholesterol lipids with contributing genetic factors are at a higher risk of having cardiac events than patients who don't have a family history. Even if your cholesterol level is the same as your neighbor's, if you have a high family history of cardiac events and your neighbor doesn't, then you're also at a higher risk of having cardiac events than your neighbor. And your neighbor might not exercise, your neighbor might eat white bread and junky food all day, and they might not have a heart attack, but you might, which is why we need to be very careful and cognizant of that and make these lifestyle changes. But the good news is that even if you have high lipids due to bad genetics, high cholesterol, high lipids, high triglycerides are very manageable. And the guidelines for management actually aren't that different from other patients who don't have bad genetics. Like we use high-dose statins on pretty much anyone who comes in with high cholesterol, regardless of your genetics or not.
So that was fantastic. So I've learned a lot, and we're still a lot to learn as well. In the triglyceride field, there's things that we're learning with the very high triglycerides that we often can use something called fibrate therapy, such as things like fenofibrate, bezafibrate. We now have a new therapy, Pure EPA, a form of fish oil, showed a dramatic reduction in cardiovascular events by 25%, probably by decreasing slight inflammation, decreasing membranes and stability of membranes and other properties, and just high EPA levels. So that's another area. So one of the things that people want to do is have a strength test and see if my arteries are okay. Well, we learned that that's an okay to start off with, or may give you some information, but gives you a false sense of security. I would rather know what my cholesterol panel is and treat my cholesterol to prevent a heart attack or a stroke from happening in the first place. And the mistake people say is that my vessels look good on my stress test and they can have a heart attack. So if you have a high genetic factor, you have positive family history, you have a high cholesterol, you're overweight, you have diabetes, you smoke, you don't exercise, you don't need to have a test. You need to have treatment. And we can refine that with some of these techniques over time. So I urge people to apply the best of lifestyle changes. Eating more plants, it's good for the planet, it's good for your health. Eating grains, and then we can talk about different forms of diet. We're going to actually explore that. So diet and lifestyle changes are the backbone. But for the right person with a high polygenic score, positive family history, or high lipid values, don't expose your arteries to things that kill. You can do something about it. I think this was fantastic. Are there any questions that people have? Any other comments anybody has to make? What are people's thoughts?
It doesn't look like we have any questions in either of the chat. We just had the one earlier about getting tests for your children, just regarding heart disease, which we addressed. And
the best test you can do is know your family history. Spend some detective work in finding that out. That's key important. And then measuring your values. And then in circumstances, we can measure other things as well if we need to. So, and don't be afraid to be on therapy. We're learning over time. When we first started in the COVID pandemic, masks were a bad thing. Now they're a good thing. We're learning about science evolves. I learned about cholesterol many years ago, and I'm glad to share this with you as much as we can. But if people want to have a natural product and thing of nature, that's fine. But if you have this genetics, natural is not good enough when you see these risks between 3 to 20 times the incidence. So be smart about it. but don't forget the lifestyle changes. And I would be foolish if I didn't start this way. Again, my dad, at the age of 50, had a bypass surgery, and that came out of the blue. It's always out of the blue. It's a sudden thing. I was fine, then I had this chest pain for a couple of weeks. I remember flying back from Connecticut as a young intern to have a bypass operation. And so, to me, is that you can prevent this. My son has a problem and he's taking care of it. My other son doesn't want to get his measure his lipids. I'll take him to the lab when he comes back from for the next little while and be tested, be treated, and make good choices. And I want to thank all the presenters for an excellent piece of work. It is complicated, but we're getting better. And thank you so much for doing this. And look at this 5 times, record this, show it to your friends, because most people with familial hypercholesterolemia are not getting pop-up treatment. And does anybody have any other final comments? Rachel, do you have do you have any final comments?
Not really. Go find out your family history, even if it's hard. I'm having trouble finding out my own family history because I know when you ask family members and you ask, what kind of disease if my mom or my grandparents have, they can be vague too. They might say, oh, she had a heart problem, she had some chest pain, or she had this surgery. Try a little bit, if you can, to really find out what it is. Find out the details. If you can't determine what it is, find out how they present it. Ask Dr. Google or ask Dr. Kernew. Pick one and see if you can get the details. Details are very important in family history. Without the details, they're not very useful for doctors in terms of determining risk.
Subin or Krishi, thank you for your presentation. Do you have any other words of wisdom you want to pass on?
No, just that lifestyle changes are very impact. So really try to focus on making those changes, small changes in your life that would really make a positive difference for like long term. That's something to remember.
Right. So lifestyle changes are important. Remember that 4-year-old that died from blocked arteries. Lifestyle changes aren't good enough for some people, and so you have to be smart about this. And so, to me, I'm learning all the time, and this has been a wonderful journey. And this is one of the huge successes of heart health. If I had to take a few things that are life-changing, bypass surgery for the first time, treatment of blood thinners and atrial fibrillation. But this ranks as the most important intervention I offer on a day-to-day basis for the people I see. And this is important. So please ask all your friends and relatives to look at this. We have 2 other excellent videos, one on cholesterol management, one on triglycerides. They complement this. I call this medical student or medical school for everyone. And knowledge is power. That power and training to action changes lives. So, and this is not the final chapter. There's much more to come right now. But wow, I first started medical practice. You had a heart attack, you got 10 years. That was good. And we also learned through genetic studying or genetic testing, if you're low risk for heart disease, you can live to over 100 years of age. And so, so much to do. And I want to bid everybody a wonderful evening. For many people, they'll be stunned. For others, they will just be enlightened, and we'll move forwards. And like I said, there's much more to come, and we're learning. And I've been privileged for over 30 years to work in this area and learn so much. And I've learned so much, and I'm glad we can share this with you. And I bid you all a good night. If those who want to, in about 15-20 minutes, I'm going to be the Shigok stairs. I just got a message from Dino that he wants to start tennis at 6:30 tomorrow morning, and that's so looking forward to that as well. I still have my weaknesses. I have a temper sometimes. I have too much Hungarian blood in me sometimes, I always say. and I still am a nighttime eater, but I'm a sweet tooth, but I'm getting better and stronger, hopefully, and I hope I can share this with you. As always, Stuart, you get the last word.
I think that was a fantastic presentation today. I don't think I can add on to anything that hasn't already been said. I really liked how we ended the presentation talking about how even if you have bad genes, it doesn't really have to be the be-all, end-all. There's a lot of things that you can do. Of course, diet and exercise isn't always everything for everyone, but for many people, it can really make a difference. And so I think just being aware of your situation, being aware of your family history, and taking the appropriate steps to kind of take control of it is the main takeaway from today's presentation. And I just wanted to thank everyone for all their contributions. Personally, I learned a lot. For someone who felt like he knew a lot about this, I think I still learned a lot. So thank you, everyone, for today's fantastic presentation.
So we bid everybody good night. And for some of us are going to just going to talk a little bit or just highlight a few things in the chat. You're welcome to join us. For those that want to get ready for the shit upstairs, I'll see you guys shortly. And if not, we'll see you next week. And have a safe week, everyone. Be healthy, exercise more, eat better, lose a few pounds for most of us. Good night, everybody. Did we stop recording?